Good morning, everyone. This is Susan Connor from the Early Intervention Training Program. We're excited to see all of you here with us today. It looks like we have about 70 folks with us today, but we expect a few more. There was a little over 100 registered, so hopefully some more will be joining us. So we're thrilled to welcome today as our presenter Dr. Rob Daniels. He's a licensed clinical psychologist and executive director at the Chicago Children's Clinic. His clinic provides comprehensive services, evaluation services and support for families around the Chicagoland area, working through challenges in terms of their child's early development. So we're thrilled that he's with us today. So again, as usual, I am one of your facilitators for the day, as is Maria Maddox.
Hello, let me first do a mic check, and if you're having any trouble hearing me, please use your chat box and let the folks know, and they'll let me know, and I can make any adjustments.
Think you sound great.
Okay, wonderful. So today we're talking about parent-implemented interventions, and this is really where the bulk of the field in the country is going, because as you know, or you should know, family involvement is so critical in the life of a child with or without a disability. And really, if you look at the delivery of early intervention services, certainly they are necessary. It's necessary to provide expert guidance, but it's not going to be sufficient. In order for it to be both necessary and sufficient, we need the collaboration, and most importantly, the effective collaboration with the parents of these children. And parents with children who are in the early intervention system are first and foremost parents. They are not consumers. They are consumers, but their primary role is parent. And so we need to really honor that relationship that they have with their entire family, not just the one or two identified children within the family, and look at ways to fold or weave the services that we're providing to them and we're asking them to provide to their own child into the fabric of their family life. And we want them to walk out of this process with a greater feeling of empowerment than when they entered it. The most stressful time in the life of a parent is that moment between diagnosis or identification of the disability and the first appointment, when they have absolutely no idea what this is going to look like, what course their child's life is going to take. And what we need to do is accept that there is that moment of stress and anxiety and start to arm them with strategies and feelings of empowerment. And there's a lot of challenges in this process. For one thing, there's typically multiple providers who may or may not be working from the same agency, or even same theoretical constructs or models of intervention. Then we have multiple caregivers who may or may not agree on the needs of their child or the best approach towards meeting those needs. And so we need to take a moment and agree on what are the priorities and who is going to assume which role. And that may take a specific set of sessions. Just to simply get on the same page and get alignment among all of the providers and caregivers so that we can start to work together in a synergistic fashion. And when we do that, the outcomes can be very dramatic and really heartwarming, and and the child is going to benefit. And when we don't do that, we're going to have less than adequate response, and we're going to have a lot of turnover and frustration, and it should be avoided. So this is a very critical point that needs to be specifically planned around for each and every client. Many times with a simple, straightforward case, the priorities are apparent, but most of the time the priorities are really a combination of the family's values and own approach to disability and services, and as well as expert opinion and evidence-based practice. And we really need to put those two things together for the benefit of the child. Today I'm going to identify specific areas to be targeted. One of the challenges in dealing with children with disabilities and identifying priorities is being able to be an informed consumer of research so that we know what goal areas are pivotal. And what I mean by pivotal are those skills that can lead to gains in untargeted areas. We could spend a lot of time writing hundreds and hundreds of measurable goals and objectives on an individual family service plan, but that's inefficient. It's going to spread your resources. But if we can focus on those key areas that have already been discovered by researchers in developmental science that lead to widespread improvement, we're going to be effective and efficient. And we really need to be both, because we have limited resources, limited time, and the children and families need to move on and overcome. To give you a preview, some of the pivotal areas that we'll be focusing on are motivation, play, and language. Motivation is key for everything. When you have intelligent children who have specific barriers or challenges and they don't try very hard, they're not going to achieve nearly as much as children who have the same barriers and challenges but try extremely hard. And so effort and motivation is critical. And we cannot underestimate the role that healthy play and play skills has on the development of a child's executive functioning skills, overall quality of life, social skills, and language development. We cannot skip over that fundamental foundational piece of skill development. No, that's not to say that we should just play with children. We need to do therapy in order to improve their play skills, and it should be playful and fun, but I am not talking about just sitting on the floor and playing. There is a specific difference between playing with the child and doing therapy with the child, and that difference can be subtle or dramatic depending on the skill set. But clearly, it isn't rocket science, but you need to apply science to the aspect of play and language development. The other things that we'll be focusing on today are parenting skills that, again, are pivotal, that lead to widespread collateral improvement in development and reduction in stress. Children with disabilities are first and foremost children, and children need sleep, and children with disabilities may misbehave, and children without disabilities misbehave. And if we can use the science of functional behavior analysis and identify positive and proactive approaches to these behavior problems to prevent them before they occur, everyone will have an easier time being effective. So part of the benefits of using this forum and platform for a webinar is the voting function. And so just to get an idea, if you could take a vote and or use your vote key, I guess, and take this little pretest of which is not a motivator to increase responsiveness
again, find your
from children.
polling function. It's that fourth icon right under your name that has a letter or a checkbox in it. And you should have choices A through E. We do ask we ask everybody to respond if they can. That way we get a really good result of responses. Appreciate that. We'll give folks a few seconds here, 10 seconds or so. All right, still seeing some more responses come in. That's good. A few more seconds here. All right, let's see how folks responded. So it looks like, again, a good majority of you identified B as caregiver-directed play being not a motivator to increase responsiveness from children. So Rob, you want to comment about that?
Sure. Well, the focus of intervention with children, some of this is very straightforward. If you want children to be motivated to play with you and interact with you, socialize with you, work hard for you, you need to provide them with some choices about how they're going to do that. Now, we're not saying we're going to give them complete control, but nor should we give the caregiver complete control of directing the play. We need to arrive at something that's called shared control. And so caregiver or therapist-controlled activities that, when I was in graduate school 20 years ago, we would start with an ABA session with a child with autism with basic compliance training. Come here, sit down, do this. And until we could establish that compliance to the adult in the room, we put all other goals on hold. Over the course of the last 20 years, we've discovered that that's not the most efficient way to address the behavioral challenges of children with autism or other disabilities. And what we really need to provide is child-directed and shared control over these activities so that we can get that motivation as a primary foundation, that they want to interact with us. And that's why they will come here. That's why they will sit down. That's why they will do this, is because they want to. And once we can get that motivation to socially interact, we can then start to impose some expectations secondarily. And so it's not a question of which is more important. It's a question of sequencing and development and order. And if we look at, therapy with other populations at other age groups, we see that the establishment of rapport is a fundamental part. And when you're dealing with a nonverbal child, a pre-verbal child, a very young infant who is, we need them to approach us, not walk away from us. And we want them to do that intentionally and voluntarily because they want to, not because we've forced them to. And one wonderful way to do that is to look at the science of motivation. And this is just motivation science. This is not early intervention specific. And if you want children to be motivated, child-preferred activities are a good way to start. Natural reinforcers, varying the stimuli. Do not come to the room with the exact same bag of toys that you've come with every single other time and expect the same level of motivation and excitement the 28th time that you had the first and second time. Now, certainly familiarity is good and routine is good and predictability is good, but we need to vary the stimuli, otherwise it gets redundant. And there's a very key point of reinforcing attempts that I will get to in a subsequent slide and spend even more time talking about that. So, thinking about this just logically, but they've also studied this systematically with large populations of children. And if we only reinforce success, and we have a child with a disability who succeeds very rarely, what we find is not very surprising. Their motivation decreases. Now, how do we know that? How do we measure that? Well, the number of attempts that they make are few. and their affect is sad, angry, or simply disengaged. Now, if instead we reinforce attempting, even if the attempts are unsuccessful, what we find is we get many more attempts. And practice makes better. It may not make perfect, but it does make better. And so what we see is because the child is making more attempts and their affect is regulated or perhaps even happy and enthusiastic, the number of eventual correct responses becomes much higher than it would have been if we had waited for a correct response before we provided any reinforcement. And so what we find, and this is across the board for motivation, this is not just with students with children with disabilities, that what the child has control over is whether or not they have made a reasonable attempt. What the adult has to have faith in is that if this child is guided and scaffolded and prompted, that these attempts will become successive approximations of the desired outcome and eventually will become a correct response. And we will have learning occur. When we withhold reinforcement after the first or second attempt because the child was unsuccessful, the child walks away or cries or simply stops trying. And then we don't have as much practice. Certainly you're going to have more you're going to have more success with 20 attempts than you are with 2 attempts. Especially when you're dealing with an area of significant weakness, which was the reason why they're qualified for early intervention in the first place. So pivotal response treatment is a specific form of applied behavioral analysis that is shown by the National Autism Center and National Standards Project and a large number of other meta-analyses to be both scientifically proven, evidence-based, and also comprehensive. So this is something that it's not just one strategy that happened to work on one skill, but this is a set of strategies that can work on a large number of, as we described at the beginning, pivotal skills, skills that result in widespread, untargeted collateral improvement. But as an applied behavior analytic technique, some things are common to all behavioral approaches. We talk about antecedents, we talk about desired behaviors, and we talk about consequences. What makes pivotal response treatment distinct from discrete trial training or more LOVAS-based, if you're familiar with that, or traditional forms of ABA are several things. One of them being that it takes a much more developmental approach toward the selection of behaviors that are targeted for intervention, in that we really look at normal development first, and we see, okay, these skills are not to be taught at random. They're not to be taught in terms of some hierarchical assessment like that an adult came up with, but these skills are to be taught in a developmental sequence and in the sequence that they would naturally occur. And when we do that, we realize that untargeted gains occur as a result. And what we do is we're very systematic about what the adult does, but we provide a lot of choice and a lot of variability in allowing what the child will do, as long as it's moving in the direction of greater developmental complexity and more developmental maturity. So things that the adult can do is when presenting the opportunity, the child or the adult should certainly gain the child's attention prior to presenting an opportunity to respond. That's just a common sense. If the child's back is to you, they're much less likely to respond than if they're facing you. And since you're the adult and they're the child, it's easier for you to move into the line of sight of a child who might avert their eye gaze than it is to wait for them to look at you. And so by proactively entering the child's line of sight, either with your face or with an object of reinforcement, something that they want, you are going to be much more likely to get the child to respond than if we don't take a moment to do that prior to saying our first word. Maintenance skills are things that the child already knows how to do. And in all learning theory, whether, again, we're working with children with disabilities, I keep saying students, sorry, children with disabilities, or children without disabilities, even adults that are listening to this webinar, a good balance is 80% of what I'm saying to you right now today, you should already know. And that will allow you to incorporate the 20% of novel or acquisition tasks and skills into your conceptual framework or schema for what you are already doing as a professional in this field. If the balance is not 80-20, but instead 50-50, you might not have enough background knowledge to really assimilate what I'm saying. If, on the other hand, it's too easy and you knew 99% of what I'm telling you already, and I am only giving you 1% of new information, you're going to lose your motivation to listen to me because you're going to feel like you knew all this already. So hopefully, as we get time for feedback, you will find about 4 out of every 5 of my key points, or 80% of my key points, familiar to you and things that you've learned along the way in the course of your career. And the same should be said for your interactions with your clients, that 4 out of 5 things that you're asking your child to do, they should already know how to do. And that will allow them what's called motivational momentum to work on those more challenging tasks. Now, if we look at this in terms of antecedents, behaviors, and consequences, what most parents fall into the trap of doing, and I'm no exception with my own children, is we see a child do something that's outside of their comfort zone. Perhaps it's the first time they've ever uttered a 2-syllable word. Well, what do we do then? Ask them to say a 3-syllable word, which will punish the child for stretching themselves outside of the comfort zone. What we should do instead is the immediate consequence for trying something difficult should be to present something easy. So they say a 2-syllable word, but they've been clapping and high-fiving for a long time. The next opportunity is a high five. So they learn that if I try something difficult, the reaction the outside world provides to me is the world gets easier, which is a microcosm of life. That if you try difficult things and you continue to practice with difficult things, life gets easier. So we need to do this on a trial-by-trial basis and be very cognizant of that. And how we do that is by selecting what we ask the child to do. That is within our control. Now, whether or not the child does it, that's within the child's control. So I always say use the serenity prayer. What are things that the adult therapist or the parent has control over? Allow yourself the courage to change those things, and then accept that there are certain things you do not have control over, but you can influence the probability of their occurrence. We'll talk about shared control a little bit later, but basically the idea is to provide choices that the adult is okay with. We're not saying you can either do therapy or watch television. What we can say is that if it's a parent who's dealing with a willful child who has a restricted set of foods that they will eat, they can eat broccoli or peas. They're both green vegetables. I really don't care which one, but it's not broccoli or pudding. And that's the type of conversation that with parents that we need to bring it down to the real world and the day-to-day interactions. Finally, what are multiple cues? Well, with children on the autism spectrum, they often will demonstrate a skill if and only if it's prompted in a specific way. And if it's prompted in a different way, they're not demonstrating that skill. And certainly spontaneous demonstrations of skills are few and far between. And that's a symptom of the disability. What we need to do is know this about autism in particular, and specifically plan for it, so that once a child is demonstrating the ability to say the word more and say the word milk and say the word yes, well, now we can use the same reinforcer that in reaction to different responses. So for example, what do you want to drink? And they say milk. They get milk. Do you want more milk? And they say yes, and they get more milk. But if you say, do you want more milk? And they say milk, they do not get more milk, because they need to learn right at the outset that conversations are flexible, and that you need to answer the question that you were asked. You cannot simply go through your rehearsed repertoire of words that you have said until you stumble upon the one that happens to get you a glass of milk when you're thirsty. You need to actually listen to your communication partner. And so certainly we wouldn't be doing this with a child who hasn't learned how to say any words yet, because we'd be happy with any word or even a word approximation. But when children are speaking in phrases, but because of their autism are quite rigid in the phrases they use and will only use them in response to very specific cues, we need to be proactive and vary the cues so that we can teach them what are the discrimination, how to make discriminations between one cue and another. In terms of how do we respond once they give us the behavior we're looking for, well, we already talked about reinforcement of attempts. We also want to provide direct and natural reinforcement. Gone are the days where you would say, what color is this? And they say red, and then you give them an M&M that might be blue. Or you might give them a cookie that is brown. Like, no. What color is this? It's red. They get to play with the red object that you were just giving them. So if it's a ball, great. Now they're playing with the red ball. If they want the cookie because it's snack time, it's fine to use it during snack time, but we're not going to use edibles away from the table, because then we have the collateral problem that they're not learning that food is to be eaten at tables, because they get to eat food on the floor while playing with objects. That's wrong. Now we've got to unteach that. Let's just teach feeding skills during meals and teach play skills on the floor. And we can teach vocabulary concepts, linguistic concepts, naturally with the objects that you would naturally play with. And when you do that, the spontaneous demonstration of skills generalized from one setting to the other becomes that much easier. And it's also easier to teach a parent how to do this, because if the parent is feeding a child, they can very easily and efficiently roll in some vocabulary development by cutting the portions into smaller pieces and using just very basic contingent reinforcement of attempts to communicate. Now, as I began this session, one of the pivotal skills and pivotal areas to target is play. It comes developmentally before spoken language. And yet, children with disabilities, particularly language impairments and autism, many times they are using spoken language before they have age-appropriate or even developmentally similar play skills. So we start with just the antecedent. We're going to follow the child's lead to find what is the toy or activity that might be motivating for them. Then we're going to create an opportunity. We're going to wait to see if the child did respond, and if they didn't, we'll provide prompting or scaffolding. And finally, we'll provide contingent consequence. If they say the wrong thing, well, we might represent an opportunity, and then if they still struggle but they're making attempts, we'll provide more support. If they were successful, then we might take a turn, and then we're going to try to provide some difference cues. I'm sure you guys do this all the time in your practice. This should not be new. The difference is really looking at it as a series of slides so that caregivers, this happens to be a grandmother with their infant grandchild, caregivers can get on the floor and apply this systematically. So if we look at how this would look, what we would see is we'd see a grandmother holding a bell and shaking it. Then that might create an opportunity for the child to respond. The child may reach, and if they reach, we're going to provide them with the bell. Natural reinforcer for reaching. Now we could do this if it's a motor development issue. We can shake the bell and be a little bit in sight and out of reach, so they need to crawl in order to obtain the bell. If it's a verbal delay or a language delay, they may need to vocalize in order to get the bell. And so, but the idea is that the bell is exciting enough to capture the child's attention, so now we have the carrot that we can use to motivate the child. Without that, if the child instead is more interested in the pop-up toy in this image, well, abandon the bell and use the pop-up toy in the same way. The child has choice. It really shouldn't matter to the caregiver or the therapist whether we're motivating this child with a pop-up toy or a bell. As long as we have the child's motivation first, we can then expect a behavior that might be on our treatment plan. So again, this is a voting opportunity, and we want to make sure that following the child's lead is something that people do on a regular basis. Parents in particular are quite starved for time, and so they may not have a lot of time to follow the child's lead. They've got one and only one toy that they shoved in their purse on the way out the door, and child doesn't want to play with it, and now they're stuck. Well, that's an easy intervention on a parent. Grab two toys on your way out the door. Now you can provide choices.
All right, so you have your...
Thank you for voting. I see that people are tapping in.
Everybody's using their poll function. Appreciate that. Give folks another 10 seconds or so to respond. Getting lots of responses, so let's see. All right, let's see what we got. Okay, let's see. Our results looks like the vast majority of folks did respond selecting A and C. A few have responded with all the above, but most responded with A and C. So, Rob?
Yeah, so A and C is correct. It's all about timing, though. So it's certainly permissible once the child has led you to an activity to then suggest what one might do with the bell. And so it's, so those of you that did say all of the above just have to recognize it's all about timing. And so if the child goes first and we imitate them, that will create an opportunity for them to then imitate you. And then you can imitate them, imitating you, and get this reciprocity and exchange. But in terms of what you would do first, as you're just setting up an opportunity, is you want to wait. Less is more most of the time with children. So wait. If you have a child who may only initiate once every couple of minutes, and a typically developing 2.5 or 3-year-old is initiating 2 to 3 times every minute, and you prompt that child 4 or 5 times a minute, when is the child going to have an opportunity to be spontaneous? You're prompting too frequently. But if instead you wait 30 seconds, 45 seconds before doing anything, they may initiate, which is one of the most powerful skills to be acquired in a language delayed or autistic child, is the ability to spontaneously initiate a social interaction, a communication, or a play activity that is social in nature. And we need to provide that opportunity of waiting in silence for the child to give us something to work off of in order to provide some instruction. So it's just a matter of timing. B is very important, but it happens after A and C. So let's just take a simple example of a toddler and a cup. So we realize that this toddler grabbed the cup. That's great. And we're going to try to gain the child's attention with that cup. And we're going to look at our understanding of development and play, of course. Play skills become more developmentally complex as the child's play skills improve. And so, it might be a simple transaction where we're dropping balls into a cup, or there might be the ability to engage in symbolic play or pretend play. And certainly we want to be cognizant of the 80-20 ratio. If we have a child who has never once engaged in pretend play, we certainly don't want to suggest to the child that we have this wonderful tea party 80% of the time and we only drop blocks in the cup 20% of the time. We want it to be in reverse. 80% of the time, it's fine to drop things into the cup, drop things out of the cup, pour things into the cup, pour things out of the cup. But then 20% of the time, to stretch the child, we're going to engage in pretend play with the cup so that they're exposed to this new, more developmentally complex concept and they can acquire it. They're not going to acquire a skill if we never expose them to it. But they're also not going to acquire a skill if we inundate them with it, overwhelm them with it when they're not even ready. So that 80-20 balance is always a good thing to keep in the back of your head and also keep in the back of the parents you're working with's head. Now, if we're not getting the types of responses we want, of course we're going to start with some prompting, but we're going to use a least to most prompting hierarchy. And the least amount of prompting to engage in socially interactive play or parallel play is to simply imitate their play. You've now created parallel play because they were engaged in solitary play and you're imitating them right next to them, so you're actually doing the parallel playing. However, watching it on a video from a behavioral perspective, the child is now engaged in parallel play. And then you can provide that difference cue and you can change the type of play you're doing with these objects, and if they imitate you, you've got them. Now they spontaneously engaged in parallel play. But it started with you imitating them. And then they later imitate you. It's just a matter of putting the cart before the horse or the horse before the cart. Works a lot better when you follow the child's lead and then they follow you secondly. But for the children whose receptive language is up to it, verbal instruction will work. If their receptive language is not up to the task, gestural prompting, modeling, visual, or then finally physical assistance. What's most important, and people often forget this, is we can create a positive feedback loop really easily when we're teaching play. Because once the child demonstrates the play skill we're looking for, we can reward the child by allowing them to play, which is the skill we're looking for in the first place. And so they can play with it any way they want, because child-directed play is a skill that this child lacks. And so giving 20 or 30 or even 45 seconds of uninterrupted access to a toy as a reward for imitating your play with that toy is not going to be a waste of time. Quite the opposite. It's going to create a positive feedback loop where I always credit my mother for this one. She once told me when I was about 7 or 8 that if I was a good boy, I could vacuum the whole house. And so, as a consequence, I really liked vacuuming. And she got her house vacuumed. And so it was a positive feedback loop that I was working to pick up my toys so that I could vacuum the house. She really got me. I was hook, line, and sinker. And you can do the same thing with play skills and children, that if they imitate your play appropriately, what ends up happening intrinsically is they're motivated to engage in these play activities, because if you're good at playing, play becomes more enjoyable. And if it's more enjoyable, you'll be more motivated to play. And more complex play schemes are even more enjoyable than less complex play schemes, so you're going to start to get some intrinsic motivation to develop play skills. And play serves a lot of very healthy developmental functions, and that's the sort of thing that you can instruct parents with. Most parents don't realize how important play is in the development of a child. And just sitting on the floor with some child-directed play has such a powerful effect on the life of the child, the developmental course of the child. And it's also so easy to do nothing for 20 seconds. It doesn't seem easy. 20 seconds is an extremely long period of time when you're nervous about your child's play or language development. But really what you're telling a parent to do, sit down, look at your child's eyes, see what they're doing with their hands, and then do it yourself. Imitate them. Slow down. And when you do that, you start to see play emerge.
Well, this seems like a good place to perhaps stop and touch bases with the questions that we are having. We actually don't have a whole lot. We did have a question about family values and culture, about child choice. So when you were talking about saying child choice should be followed, how does that relate when family values say the child has no choice in this home?
Great question. Child choice and shared control really go hand in hand. And so, what we need to understand first is, what are the parents' or families' expectations for certain times of day? And so it might be the case that it's -10 outside and the child chooses not to wear their hat and mittens, and the parents say, I'm not giving them a choice about whether or not to wear hat or mittens, it's -10 outside. And of course, that makes perfect sense, and I would never suggest that that's the type of choice you would give them. What I would say is that, look, you as the parent have made a decision that the healthiest way for this child to survive this crazy Chicago winter is to wear hat and mittens. They could choose whether they put their mittens on first or their hat on first. We don't need to have 3 pairs of mittens and 3 hats if you can't afford 3 hats, or you just don't want to buy 3 hats. But sequence of when you do something, really, as long as they're both on in a short amount of time, it really shouldn't matter. And so what we do is we find those moments in the family's life that are amenable to some of the child's choices. And sometimes there's going to be greater amounts of choice available, and other times there's going to be limited amounts of choice available. But, I chose weather as sort of this, to avoid a third rail of some other cultural sensitivities, just to give this example. But when it comes to food is a huge cultural expectation that certain families are expecting their child to sit through a very long dinner, and this child cannot. And so, then what we need to really talk about is, okay, well, what are things that are reasonable expectations? And then how do we provide some choice within that expectation that will meet the child's needs and also fit within the family's expectations? And there might need to be some movement from both at first, where, yes, we may want, where we just need to have the conversation. What's possible, what's not possible? Because certainly they can expect the child to sit for 45 minutes at dinner all they want, but that's not going to get the child to actually do it. And if that's really important to this family, then we need to figure out a solution that will actually get them from their baseline level of sitting, which might be 30 seconds, to 60 seconds, to 90 seconds, to 120 seconds, to 5 minutes, so that the parents can get involved in monitoring the progress and seeing that learning takes place over time, and that progress from not being able to do something to being able to do something better is what we're looking for in terms of growth and development. And that's the paradigm shift that that choice allows as well, because it allows for progress to occur more rapidly than if you just demand it in this authoritarian way.
We have a couple other questions. Kathy wants to make sure that she's understanding that you're saying that what about if the play isn't functional, like spinning wheels? Should we begin imitating that for a few seconds and then try to model more functional play?
Precisely. So you take this 80-20 principle that, all right, a maintenance task is this child can spin wheels. That's what they're capable of doing right now without any instruction. So 20% of the time, we're going to push the car, and then they can turn the car over and spin it if they want to. But all children, whether they have a disability or don't, engage in some non-functional play. Children spin around in circles till they get dizzy. They spin things around. The difference is frequency, intensity, and duration. That children with disabilities or play, particularly autism, engage in this perseverative and non-functional play too frequently with greater amounts of intensity and for too long of a duration. And the way we interrupt that is by meeting them where they are, imitating it, and then shaping it to a better place 1 out of every 5 play opportunities, until eventually they've mastered sequencing play into a 2-step sequence that they push cars and then spin. Well, now we can add a 3rd step to the sequence, and we start to see this developmental trajectory emerge. Instead of trying to eliminate it completely, we get to shape it into more functional play. And the tool we have in our toolbox, or the hidden trick, is that we know functional play is more fun than non-functional play. So once the child acquires the play skills to sequence play into a 3-step sequence and starts to actually enjoy how to play with the car properly, they're going to intrinsically enjoy that more than the non-functional perseverative play. But when you're very aversive and you're asking them to do things that they hate and that are too difficult, well, certainly retreating into the comfort of perseverative and repetitive play is better than the alternative you're expecting for them. So it just becomes a matter of getting into the mindset of a child with autism and saying, okay, I understand that you like to act very autistic when the expectation is overwhelming and frustrating and difficult, but what if the expectation is actually fun? Then we can convince you that acting in this very autistic, solitary way, in this perseverative way, is less fun. And so it'll be less of a battle to get them to engage in these more functional play schemes.
All right. Great questions, great responses. We have a couple more questions, but I think we're going to put them off toward the end. Just for time sake, we've got about 25 minutes left. So we'll let Rob kind of finish up the rest of this presentation, and we'll address questions at the end. Thank you.
Okay. So speaking specifically about language opportunities, we want to focus on is really using the science. Like I said, it's not rocket science, but there is science to language intervention, to autism intervention, to behavioral intervention. And we just want to put it into terms that parents can comprehend. And when we keep it simple, we're much more likely to get fidelity of implementation than if we make it complicated. That's probably one of the reasons why discrete trial training programs have less success than more naturalistic and incidental learning problems. One is, in order to be really good at a discrete trial training program, takes years and years of practice. And you need to be incredibly familiar with the science of behavioral analysis. And there aren't a lot of parents who are capable of getting that precise and taking those types of data. But if we can simplify the intervention with the same or better outcome, then it becomes a more powerful intervention because you can allow parents to take on the responsibility, a larger responsibility of the implementation. And you don't have to rely on this very small number of highly trained people. You can instead rely on trainers who have a higher level of understanding, sharing their knowledge with caregivers who don't need that much understanding. They simply need to take this nugget of wisdom you've given them and run with it and make it familiar using that 80-20. A lot of this is going to be just like parenting any other child. So an opportunity for language is any question, offer, or instruction that a caregiver provides where the child's expected to respond verbally. And so what we want to see are three types: model prompts, open-ended prompts, and time delay prompts. So I like to use the rude teenager example. Give me the car keys. You might respond with a time delay where you just look at them and wait expectantly for more appropriate and polite language to come out of their mouth. You might give them that mom look or that dad look. And then they might be like, I'm sorry, could I please have the car? Now that might not work. You might need to say, how do you ask? Or what should you say? And then they might say, can I have the car keys, please? And that might not work. So you might need to model for them. Can I have the car keys, please, Father dear? And then they may respond or not respond. That's up to them. But certainly from a motivational perspective, if you have a typically developing teenager who just happened to be rude in that particular social interaction, it's not a question of their ability to form the words, may I please have the car keys. It's a question of motivation. And when you have control over the reinforcer, you can decide what level of prompting you need in order to get the desired outcome. The same goes for children with disabilities and language delays and autism. What you expect, hopefully, will come out of their mouth spontaneously. But if it doesn't, you may need to wait. You may need to say, what do you say? Or you might need to model for them, ball, and then they say ball. But you might, after a while, you might say ball, and then they say ball, so they get it. You might say, what do you want? They might say ball, so then they get it. Or you might hold up the ball, they say ball, and then they get it. You want to use the least amount of prompting necessary to get the desired outcome. And so, as quickly as you can, shift from model prompting to open-ended and time delay prompting, because then by definition, the language leaving the child's mouth is spontaneous. The definition of an open-ended prompt is when the words leaving your mouth do not contain any of the words that left the mouth of the child. So they couldn't possibly be using echolalia in order to respond to you. So if you say cookie or milk and they say milk, that's not a spontaneous response. They simply repeated the second word you said. But if you say, are you hungry? And they said, yes, I'd like a cookie. Of course, that's very spontaneous. And what we can do is we can start to teach categories by using WH questions like, what toy? The ball. What food? A carrot. What drink? Water. And when we do that, we're starting to build the cognitive schema to organize this language that they're starting to learn. So it's not just a random set of words, but they actually fall into categories. And if we don't systematically do that with our open-ended prompts, we're not going to get the type of language organization we need for efficient word retrieval and information retrieval. Now, for a child that's pre-verbal, I like the word pre-verbal versus non-verbal because most children, in fact, with early intervention providers, you should really, if you're dealing with autism, we should really approach it with the expectation that 95% of children with autism can learn to speak verbally as their primary form of communication. The only reason if you have a child, their only disability is autism, the only reason this child with autism doesn't have a 95% chance of learning to speak verbally is if we began intervention at age 5 instead of prior to age 3. So if you're an EI provider, the research has shown that if your one and only diagnosis is autism, you don't also have cerebral palsy or all sorts of other unfortunate multiple disabilities, but you're an ambulatory, otherwise healthy child with autism who is under the age of 3, you've got a 95% chance of learning how to speak. And so, thank goodness it's 2015. We certainly couldn't have said that in 1987 or 1995. But we can say it with certainty now. What we're going to find is we first need to look at development of language. Communicative intent comes first. The intent to communicate emerges in a typically developing child at 9 months of age. Now, they're not that good at it, but they at least intended to do it. They might make a general attempt, but then next they'll approximate words, and then finally they'll imitate words. What we need to teach next, if they're intending to communicate, is that we teach them that each object has its own label, and different objects have different labels. So, at first, we might just get a vocalization out of this child. Ah? Well, that works for pretty much anything because they can't close their lips, and so it isn't reasonable to expect them to verbalize an M sound or a B sound. They only have short vowel sounds leaving their mouth. So any vocalization is going to get them some form of reinforcement. But once it's reasonable to expect them to vocalize, then they can start to approximate. So a cookie is a oi, and then milk is eh. And they start to get better and better, and they're starting to learn that eh is different than because eh is milk and is water. And we'll work on getting those lips together, and we'll work on those more complicated speech sounds over time. But what we have is we have motivation to continue to try, and we have reinforcement of those attempts. Finally, they're independently and spontaneously using the language that they have at whatever level they have it. And so, this begins in typical development with children who cry with different pitches to communicate different concepts. I'm wet, I'm hungry, I'm scared, I'm in pain. Children with language impairments might not do that, but once they do, it's up to the caregiver and the therapist to recognize that we are teaching them discrimination and object label correspondence. And eventually they will spontaneously make these distinctions on their own, even before they say their first word. Now this child, I wish we had operable video because it's the first time I caught a child's first word on video. But basically, we're presenting these two opportunities. We've got child choice, and she simply walked toward the therapist in order to indicate that she wanted one of them. She had a visual impairment, so she actually walked toward the object she wanted less than the object that she wanted more, because she walked away from these beads in the therapist's left hand, but reached towards them. And then eventually she realized, well, that's pretty inefficient. I'm kind of clumsy and I don't see very well. It'd be more efficient if I simply spoke what I wanted to say and what I wanted to receive, and that's what happened. I mean, children are going to do the most effective and efficient behavior available to them, and so many times the most efficient way to get what you want is to learn how to talk, and that's what we want. We want to create an environment where they can do that. So want to make sure that we have clear opportunities, we've provided a choice, and that if you think about the situation and you're watching it on video, anyone watching that video would be able to identify the desired behavior. So if you ask the child, what color do you want? They say yellow, they'd get a yellow marker. Natural reinforcers are so important. Parents know what their kids like, so it's just a matter of setting up opportunities for them to engage in the language or behavior necessary to get it. This child really liked being carried, and so we wrote down the words 10 through 1 on the whiteboard, and then blast off. So they had to. So this child had to say 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and blast off before he got carried around the room. That reinforcer costs no dollars. There's no sticker chart. And it's much more motivating than any toy that you would purchase for him because he just loves it so much. He also loved putting together trains. If you want to teach adjectives and attributes, you want a short or a long train track. You want curved or straight. You want red for James or blue for Thomas. You can teach these things rather quickly with using the toys you have around the house. And we want to reinforce attempts. So you put it all together and you have all of these different ways to create opportunities. A lot of this is stuff you guys are doing all the time, but you're going to want to teach them to the parents because they may not be doing them all the time. And it's okay to create a surprise or break a routine if the surprise is a pleasant surprise. Oftentimes what kids encounter is, we're going to go to the movies, or we're going to go to the zoo. Surprise, it's raining, we're not going. Well, then they cry. But how about, we're going to work on this skill that's really hard. Oh, surprise, we're not. We're going to do your favorite activity. Surprises are sometimes, if you counterbalance them, you make sure that at least 80% of the surprises that you put into a session are pleasant surprises. You'd be amazed how much more receptive to broken routines these very rigid kids with autism become. Because they realize, oh, well, I got an 8 out of 10 chance that the surprise is going to be a pleasant surprise. Okay, I'll deal with it. But you need to do that systematically.
Rob, I would just want to interrupt here for just a second, just kind of give you a time. We've got about 7 minutes left.
Okay, thanks.
Mm-hmm.
All right, so how do we deal with disruptive behavior? We want to remember that kids they're not immoral. You know, they're not doing this to be bad people. They're simply trying to be effective, and the behavior they're engaging in is the most efficient behavior that they could come up with given the situation and given what they wanted to either get or given what they wanted to avoid. And so we need to figure out what it is the child wants. And usually what the child wants is what they just got as a consequence for their behavior. So if they throw a piece of furniture or a toy, and then they get left alone in a timeout, well, perhaps they wanted to be left alone. If they bit you, they might, and then you then take them to the bathroom with you and you show them the first aid cream and the Band-Aid. Perhaps they wanted to go and acquire those objects or activities. So if we can find a more efficient way of them doing that doesn't involve biting and hitting, they're going to do that instead of, they're going to come up with a replacement behavior for that situation. Now, they're not going to be as good at the replacement behavior as they were at the well-rehearsed negative and disruptive behavior. And so we're going to need to reinforce, look at that last line, reinforce the attempts at the replacement behavior. And we want to know what it is they're communicating with that behavior. Now, in terms of just parenting, typical parenting skills are not well known, particularly if it's the first child this family's ever had and the child has a disability. So they might not know that just basic things like limit setting and handling separations and playing with their child. And so they use instead a lot of reprimands, a lot of harsh criticism that we know don't work. In fact, they inadvertently reinforce the behavior sometimes because of all the attention they're providing. And a key thing that I'll say before we finish is the importance of sleep. That children with disabilities need just as much, if not more, sleep than children without disabilities. And yet we find families that are so desperate to receive intervention for their child that they're skipping the naps, they're driving all over town, they're trying to get their child the services they need. And yet sleep is going to be one of the most powerful interventions this child could get. So we need to go through, I hope you have handouts, because most of this is just factual that we need to inform parents about. It isn't culturally sensitive, this is biological, and so we simply need to inform parents of the biological needs for sleep. And this is a great visual. It's worked extremely well for raising my own kids and all of the families that I've worked with, that we need to get bedtimes and starts of the day about 12 hours apart, and ideally between 7 and 7. And that way we can focus the sleep, daytime sleep and nighttime sleep, at the times when they need to occur. And we can also avoid unnecessary referrals for symptoms that are simply a direct result of being overtired. All overtired children have trouble falling asleep and staying asleep. And they all have sensory hypersensitivities, and they all have behavior regulation difficulties. And if we treat them all with medication or occupational therapy, it's not going to solve the problem. And if they also have a need for medication or occupational therapy, but they're too tired to benefit from it, that's not going to help anyone either. Sleep is a prerequisite. I'm not saying that people with regulation, every person with a regulation difficulty is overtired, but I am saying the converse is true. Every overtired child has a regulation difficulty. And if we can create a well-rested child, all of the severity of their other difficulties will be diminished. So for 2 to 4-year-olds, they nap less often, but they all need naps. 50% of 4-year-olds nap, so that means that if you're an EI, pretty much all of your caseload should still be napping. And while it's fine for younger children, a lot of parents sometimes they do like the 9 p.m. to 9 a.m. sleep routine. The problem with that is that these children need to enter preschool and school, and schools don't start that late. And or they're siblings of people whose life doesn't start that late. They get driven to a child care office that doesn't start that late. And so we need to give them the 12 to 14 hours of sleep a night that they need, plus the 2-hour nap that they need. And the only way to do that is with an earlier bedtime. So I'll finish with this slide because I want to save time for questions. But in terms of best practices, everyone has an iPhone or a smartphone, and you can provide video feedback in vivo with the parent when you're teaching them to be with you in your session, and just show them, look, this is what my video looks like, you video me, this is the video you look like, we want to look similar, not different, and then provide some key written down instructions for what the parents need to work on in order to work more effectively with their child. And if we have parents that are incredibly stressed out, then we may only expect them to be involved in the treatment 5-10 minutes a day. But if we have parents that are really stressed out because they just simply are lacking tools and strategies, but they want to work with their child more than 10 minutes a day, by all means, let's encourage them to do that with actual specific strategies that we can help them to provide. Now, we might shape the way we interact with parents Some parents want their clinicians to be very directive and the expert in the room, and others want to be more engaged in a collaborative process, and you're going to need to ask them. They will tell you. I think the simplest way to find out what's the cultural factor is not to make a stereotype, oh, this family's from the Middle East, they're one way, they're African American, that's a different way, these are Caucasian families, that's a third way. What we want is to simply ask them, what is your preferred way of being collaborated with or consulted? Do you want me to be the expert in the room and tell you what to do, or do you want to, be more participatory? Because no two individuals are alike. They just happen to come from different ethnic backgrounds. And if you do group research, you might find some group differences, but it really doesn't matter when you're in the room of a particular family what the group difference might be.